Good morning. My name is Judd Devermont. I'm the director of the Africa program at the Center for Strategic and International Studies, and it is an honor to moderate today's event, The Effects of COVID-19 on African States and Societies. This is an African Politics Conference Group event, and we are delighted to have so many experts in their fields to share their insights about this important development across the continent. This couldn't be more timely. As of today, there are 32,000 confirmed cases in 52 out of 54 countries in Africa. There are 1,400 deaths. And this challenge is not just health, it is political, it is economic. If it wasn't such a mouthful, I would say it's also security, it's also geopolitics. It is truly a multidisciplinary challenge, multifaceted challenge. And I am lucky that we have 4 panelists who really understand both the health, the political, the economic, and the geopolitics implications and walk us through today. So I'm going to do a little housekeeping, and then we will jump right into our moderated discussion. So first, I should let you know that this event is being recorded. It will be available online. We'll do some light editing. We'll all sound a lot smarter in the recorded version, I promise. And we encourage you to share that with your networks. And then second, we are going to create an opportunity for you, the audience, to submit questions. You can use the Q&A function on Zoom. You'll be able to upvote other audience members' questions. So may the best question win. And then towards the end of the discussion, we'll have an opportunity for all of our panelists to answer some of those questions. So without further ado, let me introduce this great team of experts to tackle this important question. Emmanuel Balogun is currently an assistant professor of international relations at Webster University. His research focuses on regional institutions, peace and security processes, and global health governance in Africa. He is the author of Convergence and Agency in West Africa, Regional Building in ECOWAS, which will be released in late 2020. So you're getting a nice preview today. Followed, we have Simukai Chigudu. He is an associate professor of African politics at the University of Oxford and a fellow at St. Anthony's College, Oxford. His new book is The Political Life of an Epidemic, Cholera, Crisis, and Citizenship in Zimbabwe. It is a study of the socio-political causes and consequences of Zimbabwe's catastrophic 2008-2009 outbreak. He's worked as a medical doctor in the UK's National Health Service before moving into academia. I bet he is thankful that he is doing the safe work of research and writing right now. We have Dionne. She is an assistant professor of political science at UC Riverside and the author of Doomed Interventions, The Failure of Global Responses to AIDS in Africa. She is also the co-host of Ufuhama Africa, which a podcast I know everyone listening is subscribed to and rates very highly. And then finally, we have Adia Benton. She's an associate professor of anthropology and African studies at Northwestern University, where she is affiliated with Science and Human Culture program. She's the author of the award-winning book, HIV Exceptionalism, Development Through Disease in Sierra Leone, and is currently writing a new book on the West African Ebola outbreak. Okay, so that's all of my reading that I have to do today. Why don't we jump into it? I want to start with the framing around how people are talking about COVID-19 in Africa. This is something that I know all the panels feel really passionately about, and we're going to try to complicate the audience's understanding of this issue. So I'm going to start with Kim. And I guess the question is Africa being treated as exceptional in its vulnerabilities to the virus relative to the way that we talk about other regions? What are the previous experiences, sources of resilience that's missing in the conversation? And then I'd love you to draw a little bit on your experience and research in Malawi, so we can think about whether or not there's a misalignment here of priorities. How do everyday Malawians think about this versus other challenges and issues in their life?
Thanks. Thanks for that, Judd, and for APCG for organizing this panel. So, like a typical professor, the start of my answer to your question is going to be recommending a book that folks should read to understand what's happening here and how we should think about it. And that's Adia's award-winning book, HIV Exceptionalism. So it's certainly about a different pandemic, but as you'll hear in my remarks today, I think there are a lot of lessons to be learned from earlier pandemics and perhaps adapted for the current crisis. So on vulnerabilities in the African region relative to other regions, I saw headlines and analysis as the first COVID-19 cases were emerging in Africa that exceptionalized the continent. For example, I'll just read a couple. So when the global north catches a cold, Africa gets pneumonia. What will happen with COVID-19? Africa has a COVID-19 time bomb to defuse. Africa's conflict-ridden regions face another existential threat in COVID-19, right? So I think what a lot of these analysts and others overlooked, of course, was how many African countries have more regularly faced deadly disease outbreaks. And so compared especially to OECD countries, African countries have some relative capacity for just this kind of health issue. So many African countries have epidemiological surveillance capacity because they've needed it in responding to the decades-long AIDS pandemic. And the Ebola outbreaks, both in West Africa in 2014 to 2016 and the still ongoing crisis in DRC, have required careful public health messaging, as well as using community health workers for things like testing and tracing, right? So testing to see who's infected and then tracing the contacts of people who have been shown to be infected. So I just want to take the example of South Africa to illustrate what I'm saying here. So it was on March 5th that the first COVID-19 case was reported in South Africa, and the government implemented a 21-day national lockdown that commenced on March 27th, which is the same day that South Africa recorded its first COVID-19 death. So South Africa has employed mobile HIV testing, often coupled with tuberculosis screening, for over a decade. And at the start of the national lockdown, South Africa's Ministry of Health deployed community health workers and at least 6 mobile screening and testing vehicles in 4 of South Africa's 9 provinces, with plans to deploy even more as they were building up their capacity for response. They want by the end of this month, for example, to have testing and screening available in all of South Africa's provinces. Now, comparing South Africa to better resource states in the global north shows a much more rapid response in South Africa. I mean, I'm an American, I live in the US. Like, I would have loved it if our Department of Health and Human Services had similarly deployed community health working teams to go out and do testing and tracing. Friends of mine who were traveling in Europe and Africa just before the US had closed travel from European airports remarked at the very different capacity for health screening health screening of travelers at various airports. So one friend of mine flew from Europe to Senegal and had his temperature taken, had a series of questions he had to answer at the airport, and then had follow-up messaging with a member of the Senegalese health ministry to check in on him to see that he was following their advice of isolating for 14 days and continuing to take his temperature and reporting that to the travel commission. Now, then when he landed at Dulles Airport, no such thing, right? No temperature taken, no caution to isolate for 14 days, no follow-up messaging, no checking in on him at all, right? So, here you have, like, people want to talk about, the time bomb, waiting to go off in Africa that is COVID-19, but I think they're forgetting that there are other places that are supposed to be better resourced, but still aren't following through this. To be sure, there are important vulnerabilities in African countries that shouldn't be overlooked, right? There was a helpful article in the Washington Post by Max Barrick and Danielle Paquette that kind of shared statistics on things like ventilators and anesthesiologists. And I think that, those are useful measures. I think that there are some more basic requirements for providing care that are unmet. Just last week in Malawi, doctors and nurses downed tools in the 2 major referral hospitals, saying, with a list of demands from government of what they needed And these were basic things like personal protective equipment that they just didn't have and, wanted to protect themselves so that they can continue to provide care. And just to your last question on how the COVID-19 pandemic may widen the gap between what donor countries deem important and what everyday people need, I think we definitely need to be mindful of that. And that's perhaps one of the most important things I learned in studying the global response to the AIDS pandemic. But I do think that there are things that could be done that would actually be good more generally. So, I'm not saying that, people shouldn't send ventilators to countries that have very few of them. But I do think, in increasing promotion of WASH activities, right? So water, sanitation, and hygiene, I think that helps with the COVID-19, with stopping the spread of COVID-19, while also promoting other health initiatives that are important, right? Health, fighting against other diseases that are endemic as well on the continent.
Kim, I think one of the issues that you're getting at, and one of the problems of the framing, is that there are 54 countries, 54 public health systems, 54 responses, and some of the framing tries to get to a mean or an average, or maybe even not that, but trying to create one single way to think about it. And Simukai, I thought you could help us a little bit talk about these different levels of effectiveness and response, and how do we make sure that we're incorporating local politics and societal factors for each of these countries effectively in our narrative?
Great, thank you very much for the question, Judd, and for having me on this panel. I guess in response to your question, I'm just going to pick up and reinforce some of what Kim has already said. Kim, I think that the headlines that you read out are really indicative of a much wider global outbreak narrative. A global outbreak narrative that tells us and, in a sense, mythologizes ideas about where diseases emerge, how they spread through different parts of the world, interconnected by a form of hyperglobalization, the trajectory that they assume, and a kind of anticipated hope that some scientific discovery or tool will ultimately resolve this crisis. Of course, a number of historians and literary scholars have written about this outbreak narrative. Famously, Charles Rosenberg contended that epidemics have a kind of natural dramaturgy that's repeated itself throughout the history of epidemics. And I think why it's useful to reflect on that is that the place of Africa, in inverted commas, as a category occupies an awkward place within these global outbreak narratives. The continent is frequently framed as the kind of primordial origin of diseases. And yet with COVID-19, with the coronavirus arising from Asia, Africa has now flipped its role into the final frontier, the point at which the coronavirus will arrive and wreak untold havoc. And in this kind of mental model of anticipating catastrophe, there's a kind of repository of stereotypes and tropes that naturalize poverty and suffering in Africa, and therefore the inevitability of tragedy. And so in this sense, the final frontier is kind of a mirror of this kind of primordial vision of Africa as the source of disease. And I think that's really troubling for a host of different reasons. One is that it kind of homogenizes the continent, Judd, as you've already suggested, that we start seeing an incredibly complex and diverse array of states grouped under one label. It belies different forms of political agency and the kinds of questions we should be asking about the strategies and tactics deployed by different African institutions or governments, as well as international institutions that are working on the continent. It diverts a lot of critical intellectual attention into kind of combating the racism that accompanies some of these tropes. So with that said, I think that the reality across the continent is one really of some radical uncertainty. I think that we're seeing the complex interplay of a number of different kinds of shocks that could potentially occur. There are good reasons to think about the public health impact of the coronavirus. There are also good reasons to think about the economic impact of different forms of response, whether that's through stringent social distancing measures, which of course we know are challenging in densely populated urban areas and in countries with large informalized economies. And all of these dynamics are going to play out as mediated by differences in the continent related to state capacity, to health systems, to demographic factors, including not only age structures, but underlying levels of baseline morbidity. And of course, the differences in political legitimacy that different governments yield. So if I could just be a little bit more specific here, it occurs to me that the South African example has on one hand been quite a compelling one in terms of something of an organized response that's operating across different sectors and is trying to forecast what the epidemic might look like there. Yet just north of the Limpopo in my home country, Zimbabwe, we're not seeing anything like the same level of coordinated action. There is a kind of follow the leader quality to the public health strategy that's being put in place. But that becomes difficult to countenance when we think about the fact that for a long time now, the Zimbabwean government has been in a really protracted set of disputes with its healthcare workforce over labor rights, working conditions, and remuneration, where there have been instances of violence and abductions that have been meted out against healthcare workers specifically, as occurred when a trade unionist doctor was abducted last year. So these are some of the contextual issues that are going to really complicate aspects of, say, the Zimbabwean response. The beleaguered kind of Ministry of Health is desperate to organize and to coordinate response, and yet it appears to be very fragmented. So the contacts I have there are complaining that bringing the public and the private systems into alignment is going to be a big challenge. And I think that we see versions and iterations of this medical pluralism in different parts of the continent for different reasons. And so I think that all of this kind of compels us to think a lot about the various political circumstances of different countries and what they're able to do. I won't speak too much about some of the economic dimensions, but just to say briefly that there is also this question of the kind of fiscal space that different countries have in order to provide social protection to communities and to peoples when models of lockdown are put into place. And so I think we're really dealing with quite an uncertain and complex and diverse array of issues. So I sort of before wrapping up, I kind of echo as a starting point, taking seriously Alex Duvall's sort of injunction that you should know your epidemic and then act on its politics. But this, of course, is a point of departure and not one of arrival.
I think that's a great place, though, for us to pivot to Emmanuel, because I'm not an academic, so I'm going to keep pushing our panel towards policy. Apologies, it's just the way I'm wired, and I do worry about and wonder how the framing, all the issues that Simukai and Kim just raised about the problems of the narrative around Africa and COVID-19, does that change the way that the international community and the domestic governments respond to it? And particularly thinking about certain equipment, right? Every article, and I do this too, right? I talk about the number of ventilators in CAR or in South Sudan, but then thinking about the kinds of interventions or what are the right actors. I mean, the narrative isn't just academic amongst academics. It does change the way we think about what are the right interventions. So Emmanuel, I thought you could help us think about how narrative meets response.
Yeah, great. And I want to echo the other participants in thanking you all for the invitation and for African Politics Conference Group in doing this. And so I'll also echo Kim and Simukai in the sense that I also see that there are two, in the international and domestic response, there are sort of two essentializing frames at work here. One is this response frame, and I would say the other one would be this preparedness frame. And so, again, not to, beat a dead horse, but sort of the response frame has been, on an international level and on a domestic level, it's been a lot about this, a lack of a one-size-fits-all approach to responding to COVID. So this is the frame that sort of suggests that responses like or mitigation tactics such as social distancing, isolation is not possible in a place like Africa, quote unquote, because of sort of the communal conditions there in most urban African cities, the hand-to-hand economy of most African cities, and also sort of the different customs in these societies. And also, I did sort of a similar thing that Kim did in looking at the headlines, but if you just do a Google search of social distancing in Africa, you'll see anything from it being a privilege to it being not possible, and all these other sort of challenges associated with it because of, again, this exceptionalization of Africa as a sort of a continent that's not industrialized enough to or capable of isolating, right? You also, as Judd, as you mentioned as well, you also start reading a lot of sort of the responses have been framed around the lack of personal protective equipment, particularly ventilators and masks and things of that nature as well. And then the second frame, I would say, of preparedness is also to what Kim started the conversation out with. Talks about the ability or the capacity of African countries in their ability to deal with public health emergencies, and that because of their experience of dealing with things like HIV, Ebola, cholera, etc., that they're equipped to deal and engage with the type of isolation needed to mitigate the spread. And so, as many of you, as the previous panelists have mentioned, South Africa has been an example here, and they've been lauded in terms of their response to using the responses to HIV and tuberculosis and applying those lessons to COVID and flattening the curve there. However, I think that there's a sort of, this framing creates a schism in the narrative and response between African governments and how they're engaging. Particularly if we think about the ways in which, on a continental level through the African Union and its specialized organization, the African CDC or African Centers of Disease Control and Prevention, they've done, and I'll talk a little bit about this more hopefully later, but they've done a lot in terms of aligning with the World Health Organization to develop a harmonized response across the continent. But also there's this tension in dealing with member state capacity, right, or the unevenness of member state capacity on the continent. And so you could take, for example, Ghana yesterday was the first African country to lift its coronavirus restrictions, lauding with the president touting the increased capacity for Ghana to do testing, right? But in neighboring Togo and Benin, those the capacity for testing is significantly less. And so for the ability to sort of harmonize this response has been, or at least these narratives to talk about the ways in which Africa is making progress on harmonizing their responses seems to be limited as well. But the frame also sort of just privileges, the framing that we're talking about here also privileges sort of this common guidance for citizens of African countries to do community social distancing, washing hands, personal hygiene, using of masks and others. I think sort of focusing only on these facets of response sort of undermines the ways in which there's a real concentrated effect by particularly African regional organizations to harmonize and have a collective response, particularly also when it comes to tracing and testing and information sharing.
Great, Emmanuel, and I know we're going to get back to some of these issues around regional harmonization, but I want to pivot a little bit to some of the risks posed by the virus, and particularly the lived experiences of Africans in various countries. And Simukai, we're going to promote your book again and say that, your book, The Political Risk, The Political Life of an Epidemic, Cholera Crisis and Citizenship in Zimbabwe. I mean, you talk about the social and political causes and consequences of the outbreak in 2008 and 2009. And so I'm hoping that you can leverage some of that insight to help us today to think about what are the real pitfalls in a country or government's response to COVID-19.
Great, thanks very much. So just for a little bit of context here, my book studies Zimbabwe's cholera outbreak. that began in August 2008 in the high-density suburbs of Harare's metropolitan area. And that disease rapidly spread into peri-urban and rural areas before crossing the country's borders into South Africa, Botswana, Zambia, and Mozambique. It had an exceptionally high case fatality rate at the peak of the epidemic. And over a 10-month period, cholera infected 100,000 people and claimed well over 4,000 lives. Now, Tony Barnett and Alan Whiteside, in their study on the social science of infectious disease, have written that the conditions that facilitate the rapid spread of infectious disease are also, by and large, those that make it hard for societies to respond and ensure impact will be severe. In the book, I tried to show this in part by highlighting, I think, 3 key factors that essentially allowed what is otherwise a simple bacterial infection to become a massive calamity. One of the factors was Harare's or Zimbabwe's hydraulic crisis. This is the failure of water systems throughout different parts of the country. Now, there are some political reasons for why these water systems failed. They've got to do with disputes between the ruling party and the opposition over who had the proper right to manage water at a city level. And so in the early 2000s, Zimbabwe had nationalized its water services, and the ruling party essentially displaced opposition-run municipalities from water management. Which then created a source of rent seeking as water rates were paid to the new nationalized water body and then redirected to the ruling party's operations. So there was some nefarious politics going on. At a material level, this meant that years of capital investment in infrastructure were lost. When water pipes burst, there was no one to fix them. And ultimately, the water delivery system and the sewage system broke and kind of cross-contaminated with each other, further facilitating the spread of the disease and making it very hard for people to practice clean and safe hygiene and sanitation. Those kind of structural conditions in terms of water have persisted to the present, albeit the politics has kind of continued to be in flux. And so I think that that's sort of one key area we might look at in the Zimbabwean case that would make us worry. The other thing that's closely related to it is that access to water is really differentiated along socioeconomic lines. So middle-class households, those with greater access to money and resources, are essentially able to buy water privately, have it delivered to their homes in water bowsers, or else access it through boreholes that don't exist in many of the high-density suburbs that circumnavigate urban areas. So I think we're right to be anxious about the potential for not only a pandemic being kind of enabled by these conditions, but also mapping onto pre-existing forms of socioeconomic inequality. The other issue that I look at is I'm interested in the kind of the sort of structural factors that led to the outbreak, but the kind of subjective experience of what it was like living through a really ugly disease. And something that came out consistently in the work that I did with people living in high-density suburbs was that they understood and explained the cholera outbreak in relation to changing political and economic circumstances. So the failure of water systems, the inability of the national system, the national health system to respond, was seen as evidence that people living in urban areas were disposable, that they did not belong within the body politic, that the ruling party was a sinister regime capable of punishing its citizenry or else neglecting them in times of dire need. And I think under such conditions with these state-society divides, it creates a lot of room for misinformation or the circulation of rumors and so on. So to give one example of this, during the cholera outbreak, about 3 months in, the Minister of Information at the time, the late Dr. Sakyanyiso Ndlovu, came out and said that cholera was racist, terrorist, biological warfare from the West to undermine the sovereignty of the ruling party. When I spoke to people about this, years later doing my research, they all said to me, actually, there was biological warfare, but it was not the British. It was ZANU-PF itself that was launching biological warfare against its own citizens. Others took a different interpretation and said that the problem was the Chinese, who had been providing the Zimbabwean government with fake chemicals to treat the water supply. But those fake chemicals were ineffective, which is what explained why sewage would flow from their taps. So this is a way of saying that something as mundane as infrastructure or the delivery of water services is endowed with social meaning according to a much wider political context at play. And that these conditions shape the reach that public health messaging might have. And I think Shireen Hamdi's framing of thinking about disease in terms of its political etiologies, i.e. how people understand the origins of disease in relation to their political imaginaries, is a crucial part of the lived experience of an epidemic.
That's great. Thank you for that. Adia, I'm going to bring you in, and thanks for your patience as we've gone through a couple of topics, but I'd really like to hear your thoughts on this big debate around lockdowns versus livelihoods, which we've all kind of talked about a little bit, but it seems to get a tremendous amount of attention, in part because I think we're struggling to find what the right intermediate steps are and what's the best sort of prescription for addressing the public health dynamics and threat, but also making sure people can work and they can eat and they can have access to markets and their children can study. And I was hoping that you could help us think through what's the best approach. I know we've talked a lot about South Africa, but if there's other countries that we can highlight as doing this quite well. And then this gets to something that Kim said earlier, but is the risk that COVID-19 just diverts our attention from other public health challenges?
Oh, that's a lot. Well, mostly because I've been struggling with this idea here, right? As I'm sitting in my basement, listening to my children run around crying. But there's like so one of the things that I've been thinking about, particularly as people start to kind of complain that, and this is a complaint, why didn't China tell us earlier so we could lock everything down and all of this stuff? And, why didn't the WHO do this? And I often have to explain, well, the international health regulations absolutely caution against stopping trade, against travel restrictions, against all of the things that were actually China's first response, right? And there's a reason for that. The international health regulations are absolutely, first and foremost, always trying to balance the economics and the health, public health. It is never a disentangled relationship. And there are reasons for that are, obviously centuries old. So I've been thinking about this a lot, particularly for Sierra Leone, where the first instinct wasn't actually to shut down everything, but to shut down schools. And start their radio program, which they started during the Ebola outbreak. So for people who don't know this, Sierra Leone obviously had this, had a cholera outbreak in 2012. It had this outbreak of Ebola between 2014, 2015. And so the schooling question was never the big question. Like we do radio programs, we start this sort of distance learning modality, we're ready and set up to do that. Unfortunately, that again also reinforces existing rifts between people who may or may not have really good access to the radio, oddly, or other forms of distance and mobile learning. That said, one of what I would like to imagine and think about is that we would have, because of our long or extensive experience and repeated experience of having to deal with these acute crises, that we would try to mobilize and look not to Europe or North America for our approaches, but to Asia, which did not lock down, I would say, excluding China and Japan, but parts of it like South Korea and Taiwan that were able to actually rapidly mobilize testing and rely on people's willingness and ability to be not only subjected to testing, but to restrict their movements upon recognition that they had been infected. and then shaping activities around that. One of the framings that you guys have all talked about is this idea that the low-tech solution is the African solution, but I'm not convinced that that's the case. There are partnerships, including the one between Senegal and the UK to develop, unfortunately, just antibody tests, but bear with me, but with diagnostic tests and low-cost ventilators. So I would say we're looking to the wrong people for our examples. We need not to look at Europe. We need not to look at China. We need not to look at North America, because that's not where we're seeing the success. We need to be thinking about those. The other fortunate thing, and I think I'll talk about this later, is that many of the countries we're talking about have strong partnerships with countries, and so are much better at doing collaborative work than, say, I'm sitting here in one of the hotspots now, and all I can think about is, if only we were very much connected to other communities in ways that allowed for collaboration, allowed for door-to-door health education, allowed for rapid response, then maybe we would be somewhere. And that is something that we actually do have under, in at least in places like Sierra Leone, where we've had to mobilize huge groups of people to actually do health education, to actually deliver good information. There are people around me who don't even know why we're isolating right now. and it bugs me. So I feel like I'm kind of talking around the issue, but what I think we have, at least in the African context, is the ability to stop things quickly, to shut things down, but we also need these social safety nets that work in collaboration with these other sort of individualized and community responses that scale up. I feel like that covers part of it, but I feel like I also have more to say later.
Well, yeah, no, but that's great. That sets us up, I think, for some of the subsequent questions that I want to ask. And I'm really glad that you mentioned South Korea, because President Moon was just about to really launch his Africa policy. His foreign minister had traveled at the end of the year, and so I think that South Korea is in a place, or Seoul's in a place, where because of their successes and this burgeoning relationship they're trying to have with African counterparts, whether or not there could be a greater exchange, for Africa looking east, but not to China, but to South Korea. So Kim, I'm going to give you my favorite question for this section, which is the politics, right? That's, what does this mean for governance and democracy? I know all of us have been thinking about, what is the risk that a government could use the pandemic to muzzle the press, to suppress the opposition, and then a bigger question about, like, what are we going to do with the 15 elections that are sort of on the calendar between now and the end of the year, and what are the trade-offs that we have to think through, or governments have to think through, between the democratic imperative but also public health?
Great. Yeah, I think I think a lot of people, especially people who are trying to follow what's happening closely in Africa, are disturbed by the multiple reports of soldiers and police officers using deadly force to enforce national curfews and lockdown orders. So, for example, in Kenya's capital city, Nairobi, in late March, there were residents in the Matari neighborhood who had reported police were using tear gas, shooting guns in the air, and then, of course, one of the people living in that neighborhood was killed because of the actions that police were taking. And just a couple of weeks ago, actually, the Nigerian National Human Rights Commission had released a report saying that more Nigerians had died from aggressive enforcement of COVID-19 lockdowns than from the coronavirus itself. Right. So I think we really do need to think about state response and how there are consequences of how states respond, not just for human rights and like civil rights and liberties that people are supposed to have, but also for actual like health consequences. And I think that we should be concerned that those African states that have engaged more regularly in violent repression may use the threat of COVID-19 to justify using deadly force, potentially targeting opposition or activist organizations, just like states can draw on their previous experience and relevant capacity to handle epidemics. states can also draw on their previous capacity to repress citizens in the name of health security. I think that, you know, the earlier scholarship on regime type and health would lead us to expect that citizens in democracies may get more or better health services during the COVID-19 pandemic than their counterparts in autocracies. But of course, you know, I'd say that that's still speculative given the nature of COVID-19, and I think that a lot of the earlier takes were that, well, maybe being an authoritarian regime is better because they can lock everything down. But as Adia pointed out, you know, there's reasons why you don't want to do that. And I love the South Korean example, especially as we're talking about elections, because South Korea had elections. You know, there are great videos on Twitter and YouTube where you can see how they were able to manage elections even through a pandemic, right? And the comparative case, right, is Wisconsin and Milwaukee having so many infections because there were no precautions in the United States for this, you know, for this election that had just happened in Wisconsin, and multiple people got infected, not just poll workers, but people who visited polls. And, you know, we just had an election in Mali, and we're, you know, again, like, you know, there was lower turnout for the election, I'm sure, because some people were concerned about, you know, not just COVID-19 infection, but other potential problems with the elections. And I think that, like Adia said, I think that South Korea would be a great case for everyone to learn from and potentially to partner with. And I think I'm worried in Malawi. There's supposed to be fresh elections in July following a high court decision that the May 2019 election outcome for president was invalid. And I see the president trying to use this crisis as a way of harnessing more power. It's not working. Certainly Malawian citizens and the effective opposition parties and the really engaged civil society organizations are pushing against it. And so far they're able to check the president's power. So it's just, we're just gonna have to wait and see.
Yeah, I've been thinking a lot about you know, there's not a right or wrong answer to whether you have an election or you delay it, right? There's only a good or bad process. And I look at Abiy Ahmed in Ethiopia that had an institutional support, inter-party support for the delay, and then in Guinea or in Mali, where there wasn't a consensus and there wasn't preparation for it. And so I think that's, for me, that's how I think about it, is that you've got to have an agreement across the political elite and the citizenry about what is the right way to proceed. And then from there, you can think about the health implications. Let's spend a little bit more talking about the bilateral and multilateral approach. Emmanuel, you kind of gave us a nice preview of the way we have to think about a harmonized approach in the region. So your research is on ECOWAS. I'm going to also ask you to talk a little bit about the AU. And if you could give us a sense of how they're responding to this, what are the challenges that they may face, and what are the things that, what are the reforms that could really unleash this regional approach to this problem set?
Yeah, great. And so I'd say, you know, since the Ebola virus outbreak in West Africa in 2014, 2016, the African Union and ECOWAS have, in particular, have accelerated their developments of respectively the African CDC and the ECOWAS Regional Centers for Surveillance and Disease Control. Particularly with the Africa CDC, it's taken a multifaceted approach in its response, notably through the creation of a clinical community of practice. And so this is a group of over 700 health practitioners across the continent. And the Africa CDC hosts a weekly webinar for health workers on how to treat COVID-19, and also shares a bunch of resources on how, including peer-reviewed scientific research on ways in which national governments or member states of the AU, or just anyone who, or community health workers on the continent can develop knowledge to share with their communities. And so the African CDC has been really trying, at least to drill down to the community level, to share information about how to respond and deal with COVID-19. On a more sort of regional, international cooperation piece, African Union is also, actually since December, has established a partnership with the World Health Organization, and as recently as I believe a couple of days ago, has established a codified partnership in developing the partnership to accelerate the COVID-19 testing, or what they call PAC-T3, which focuses on testing, tracing, and tracking. And so what this initiative will do is, with resources from not just the World Health Organization, but UNDP, World Food Program, will establish warehousing and distribution hubs across the continent to help support, and then also provide support for over 1 million, support for capacity for 1 million tests for COVID-19 for Africans over the next 10 weeks. And then they'll also work to standardize testing technology to improve public trust in testing and forecasting of the disease. On a sub-regional level, I'm most familiar with ECOWAS, and what their regional, what their specialized agency, the West African Health Organization, and their Center for Disease Control, they've been able to distribute over 30,000 diagnostic tests across the sub-region of the 15 member states of ECOWAS, 50,000 specimen transportation kits, and also over 10,000 personal protective equipment, along with some essential medicine as well. And so there you can see, so there's a concentrated effort, to provide technical capacity, technical support to African Union and ECOWAS member states in dealing with COVID-19. But despite this ability and aptitude for organizations to harmonize and collaborate, the challenges they face is that there's a lack of reliable community health data. And so getting real reliable information on how to do contact tracing, for example, has been difficult. Also, as I mentioned earlier, and as many of us have also alluded to, there's just this uneven capacity of member states to apply the suggested standards of the African Union, of the World Health Organization as well. So one way I think we can potentially unleash the potential of these regional approaches is to think about the way the abilities and the actors within these organizations, particularly the health ministers of respective countries, but also the bureaucrats within these organizations that help sort of facilitate the day-to-day and the community interactions between the organizations and particular communities within member states. And one way I think this is possible is for health ministers to help prioritize within sort of the higher ups of the African Union or ECOWAS in the West African case, the need for emergency spending in the health sectors to improve health systems. Up until now, it's taken lots of creative measures and maneuvering from practitioners within these organizations to seek resources and partnerships with international organizations, with international development groups, donor agencies, NGOs, etc. And so I think these organizations, particularly the African Union, needs to establish more of a presence, and this might be a longer term solution, but more of a presence within the member states, particularly in helping facilitate their health service provision and health service delivery, and also lean into some of the science and knowledge creation coming out of these communities of practice. So I think this is it's a good first step to develop this clinical community of practice. I think lots of African health practitioners and health workers have taken advantage of it. I think a next step for a way to transform it and make it more powerful would be to allocate more national attention from governments, with the impetus from the African Union or ECOWAS in that case to better resource them.
Thanks, Emmanuel. Adia, I may give you it's not the hardest question, but it may be the one that's most fraught. I mean, here, at least in Washington, D.C., when I'm not living in my house and working in my house, this is the question that people, I think, struggle with the most and probably expend the most energy on thinking about. But what does this tell us about Africa's international relations? How would you assess the way that the international community has responded? And then, do you have a sense of how African publics and governments are evaluating and judging and scoring the response from whether it's the U.S., China, we talked about South Korea, we could talk about Cuba, which is, you know, still doing its medical diplomacy. But what is the international relationship? What are the effects on international relations?
It's funny that you say that, because when I was thinking about this question, I was like, so what would the US be doing under these normal circumstances, right? Like we're putting out our own fire. For what it's worth. I mean, which isn't to say that USAID suddenly stops working, right? We know that people are still doing the work that they're doing, but one of the things that we learned in Ebola was actually like foreigners were scared and freaked out, and either they evacuated essentially, right? So Peace Corps shut down first, and then everything else sort of went astray. And which isn't, and then we had this sort of, what we had is the shift from sort of the day-to-day, everyday sort of development nitty-gritty to something that looked like an emergency. So people who were kind of sacrificing their own safety for the benefit of the sort of poor other, right? And so I'm not sure that that's happening here. What I'm have been thinking about more broadly is how this is another instance of us moving from crisis to crisis, rather than exceptionalizing this disease, which is why I guess I probably should have talked about my work. I don't know.
Still have a chance. You can talk about it.
I mean, hey, why not? But it worries me that we're now kind of again retooling or reorienting health systems towards a single pathogen, rather than thinking about how we might flesh out and really build up health systems more generally. One of the things that troubles me when we talk about ventilators, you know, Senegal making those 3D printed $60 ventilators. I mean, hey, it's sexy, right? But one of the things that bothered me when I heard about the ventilators is I was like, what about oxygen? And what about like just having beds that people want to go to and not have to worry about like supplying medications? And, you know, like I just sort of, it was like this very basic sense of like, what would I do under the circumstances as a person who is middle class or whatever, living in the countries that I have lived in. So I guess what I would then say is when we're thinking about something like, we're thinking about ventilators, which are technically going to go to a fairly small number of people who are infectious, we have to also imagine that there's a whole group of people who still need care for the conditions that they present with. People who still, and that is a system question. Whether we can trust those systems. I think we're a little bit ahead in terms of existing programs that have been about developing the capacity of community level responses to diseases. So I would say in terms of foreign relations, the extent to which our relationships are intensified under emergency, I think are questionable because of the fear deriving from our own, well, the fear of the virus itself, but also our inability to curb our own, to deal with our own problems. And that's actually been the background question for a lot of things dealing with African relations with Europe and North America in particular, right? Is how can you be trying to help us when you can't even help yourselves? When you can't even fix your own problems? And this is actually one of those extreme and obvious cases in which I'm not sure that the US is actually equipped to offer assistance, technical assistance, for this. Maybe I'm wrong. Although we probably could be using many of the strategies we've been peddling in Africa. Like we've been saying, oh, the community health volunteers can do that. Sure. You know what, it would be really great is if health systems were actually like, there's a primary care system, and then there's a secondary, and then there's tertiary care in the district hospital. Why can't we have that system in the States? I wonder. It's because we have a very different kind of political economy of health, right? That said, that would be my question, to flip the foreign relations question, which is the extent to which we have learned from the global lessons that we claim to be cultivating as a result of our interactions or engagement in African health systems. We need to think about science. So we've talked about diagnostics and the rollout of diagnostics. Are there ways that this scientific work and scientific knowledge production happening on the continent does not become a relationship of exploitation and extraction? Because that was absolutely the question with Ebola. Samples migrated out to Europe and North America. I'm very happy that there's an African CDC, but it's modeled on the US CDC, and it sits outside of the other health, issues, and it is an infectious disease outbreak response agency. It is not a health agency. And so we kind of have to, which isn't to say that the US CDC is an outbreak response agency. It actually does everything, but for some reason, the only thing we export is outbreak investigation. No idea why. I'm rambling, but that's ultimately what I'm trying to say, is that we need to I think this is actually an opportunity to reassess what it is that we think we're doing, we being sort of the West, are doing with African health systems, what African governance is thinking it's doing with African health systems and outbreak response. And this is an opportunity to maybe reshift and rethink how this can be leveraged to focus on developing real health systems.
I really like that answer, and I think that you're right. There's a lot of lessons that the U.S. and Europe and others can be learning from the way Africans respond to these health challenges. And I actually think it's part of a bigger conversation too about just the state of democracy in the West and what we could be learning from Africa in terms of, with such a high level of trust still in democratic practices and the way in which civil society has been mobilized in certain cases to beat back autocratic tendencies of leaders. So it's a really rich vein that you're bringing up. I'm going to hold back my last question till the end because we've got a whole mess of questions that people have been pouring in, and you've been voting on it. So this is kind of like American Idol meets an academic conference. And so we're just going to go with the first one, and I'll throw it open to our panelists, and maybe one or two people, if you feel this is your question, jump on it, and then we can go to the next question. But this is from Justine Davis and Brian Klein of UC Berkeley. They note that Madagascar is manufacturing and distributing a chemical called CVO, or COVID organics, comprised of locally grown artemisia and other medicinal plants that the president has said is both preventative and curative. He's reopening the country. Students are heading back to school. Offices and businesses are reopening. And then Senegal has placed an order, although I think there's been some debates around this. How are folks thinking about this development, its promise, dangers, politics, and the way it's being discussed in the media? So that's a meaty question. Who wants to jump at it?
I llove how Adia sips tea.
Yeah.
She's like, oh, I'm not going to touch this one yet. So I'll just say that, during the AIDS pandemic, we've seen multiple claims about curative treatments. And usually, I think the most concerning claims are the ones that come from presidents, right? So Yahya Jammeh of the Gambia had claimed to have a cure for AIDS, and that's why he was going to eradicate it from his country. I don't want to minimize the potential possibilities of artemisia and other medicinal plants in whether it's alleviating, the pain associated with COVID-19 or some of the symptoms associated with it. But I do think that if there's anything that, as an American, right, watching the regular news briefings about what's happening, I want less of the politicians talking and more of the people who actually know something about community health and science, right? So I, I would really like to, I would hope that just like I think many citizens, they want to listen to public health messages from people that they already trust, And so I think it's going to, these kinds of things, it's going to depend on how much people trust their leadership, whether it's their national leadership or local community health workers, to disseminate public health messages to them. And I'm happy to be wrong if CVO is really in fact curative, but I'm always worried when there's an announcement like this from a president, as opposed to a researcher or someone who actually works in community health.
That's a fair point. Others want to try this question, or do you want to go on to the next one? All right, I'll take your silence as interested in moving on. So number 2 by your votes is last week Saudi Arabia expelled thousands of Ethiopian workers back to Ethiopia for fears of coronavirus spread. Given the high levels of intra-African labor migration and previous xenophobic attacks in places like South Africa, do you anticipate similar targeting of African foreign workers within the continent and possibly expulsions? No tea drinking. Adia, you want to try it?
Sure. I think a lot of us have already pointed to how the politics that pre-existed the pandemic get reproduced through the pandemic, right? And so it seems that whatever kinds of tensions, racial, ethnic, or otherwise xenophobic violence will somehow be exercised through this thing. We're seeing it again in the United States, including that chloroquine thing. So it seems to me that this would be heightened under these kinds of conditions, particularly when labor and work are at the center of those questions, right? Because that is where we are being hit the hardest when it comes to the interventions dedicated to curbing the spread of the virus.
Anyone else want to take a hit? Simukai?
Yeah, I just wanted maybe a brief comment on this, because I fully agree with what Adia's already said. And I think situating this question with our earlier discussion about outbreak narratives, I think brings out, one of the big contradictions of, in a sense, global politics. Because on one hand, we're coming to understand the coronavirus is being framed as the quintessential pandemic of globalization, right? So a virus that originates in the wet markets of Wuhan in a kind of densely compressed, highly interconnected world is able, to spread with rapid speed and shows no respect for borders. And yet at the same time, the response to the outbreak reinforces all manner of different kinds of nationalisms and parochial identities. Priscilla Wald refers to this as imagined immunities, as a kind of play on Benedict Anderson's imagined communities. The idea that kind of nationalism and state sovereignty is kind of mobilized as the appropriate kind of organizing community for dealing with outbreaks, even those of a particularly global origin, and of treating carriers of or potential carriers of disease who are somehow other as being especially dangerous. And of course that amps up or heightens anxieties about migration and aspects of globalization that already exist. And so there's this kind of weird hybrid where the most sinister aspects of how the virus is imagined are then grafted onto the identities of individual human beings or categories of human beings. And so I think that that's kind of one of the big dilemmas that and challenges that exists in the kind of global national tension that this pandemic is bringing out.
All right, let's take another bite of the apple of the China relationship. We have a question about how this could change international relations with countries, specifically China. Although, again, I think you have a wide berth if you want to talk about other countries. And there's a lot of aspects here about the xenophobia within China and the racism, but maybe I'll just broaden it a little bit to think about how different countries are doing mass diplomacy right now. So whether it's China, the US, Cuba, UAE, and how do we think this may or could change trade relationships, or again, as I asked Adia, foreign relations?
I'll take a stab. So I think, one way in which this is going to affect trade relations on the continent. So, as many of you may know, the African Continental Free Trade Area was supposed to launch this year, and I believe it was just announced that it was going to be put on hold for this year. And so I think, or at least delayed. So I think one of the implications of that is that this might, by means of necessity, force African countries to sort of re-entrench their existing ties internationally. And so while the relationship, or the attacks on Africans in China have been disheartening, I think in terms of trade policy or economic policies, or in the ways in which the China-Africa partnership has been deepened over the last few years, in order to sustain some sort of economic viability and connectedness to the international community, I don't expect COVID-19, at least in the short term, to upend these existing relationships. And I think African leaders might, I would imagine that some African leaders might think about preserving these relationships in order to retain some sort of presence in whatever the global economy is left after this. However, I do think, and maybe maybe in the long term though, I think this is, especially as you're bringing up, Cuba, and I think there's a delegation of Cuban doctors to South Africa recently as well. But I think this might be an opportunity or an opening for more robust South-South relations, particularly between places like Africa and South America, or the Caribbean in that regard. So I think in the short term, I wouldn't expect to see a fundamental shift in China's relationship with Africa on the aspect of trade. And I know there's some worry about Chinese governments now calling for debts to be repaid under this. But I think in the short term, I don't anticipate there to be some sort of catastrophic shift in international trade dynamics.
One of the more optimistic thinking about post-COVID-19 is that perhaps some of the supply chains will move closer to the continent, or could this accelerate the CFTA? So I think, it's early days, but that's at least one of the ways I've heard people talk about trade relations, not just shifting, but actually sort of creating a new. Let's move on to the next question. It touches on some of the things that we've already been discussing, but maybe there's additional points that others want to add to it, which is, how are ordinary people weighing the risk of COVID-19 relative to other endemic diseases? Kim.
No, Adia was first.
Well, I actually was just wondering if anyone's actually been looking at that, because one of the things that I wouldn't necessarily think in terms of diseases, but just sort of regular care in general. Mm-hmm. So during Ebola, there was a lot of questions about whether you seek and how you seek maternity care. Particularly if you have a complicated case, and that's certainly been true in the States. I've had a few friends schedule their deliveries, right, who just because they weren't sure. And I've just had an email from a practitioner about an appointment I had next week, and which is quite serious. And so I would be concerned about the ways that COVID is helping to marginalize other forms, the sort of basic forms of care. And there have been discussions about, say, places that already have, say, an Ebola outbreak, like the Democratic Republic of Congo. There's also there's also there's several measles outbreaks going on right now. And so how would how are these overlapping epidemics being addressed? Because they're different routes of transmission, they're different kinds of treatment, different means of preventing them. And so I would be concerned about again, rushing to the crisis and how that absolutely marginalizes forms of care and shapes how care can actually be delivered in whatever form, outbreak or not, or endemicity or not, because people are still living their lives. One of the things that we do know, though, is if people are decreasing their contact for other reasons, those other, it's possible that infections that are transmitted that way are coming down, but people still have other lives. So high blood pressure, some of my neighbors in Sierra Leone had, due to their using HIV drugs. There are people who have these sort of ongoing conditions that certainly will be shaped by what we're doing for COVID. So.
Yeah, and I just wanted to answer this question. I really just want to echo what Adia said earlier in comments about health system strengthening, right? So that I don't want to pit COVID-19 against other potential health conditions, right? And I don't think regular everyday people are trying to do that either, right? I think the answer is, strengthen the health system, and it can fight all sorts of things, right? And I think, but if I were to talk about the exceptionalism of the disease, I wouldn't talk about it relative to other diseases so much as other issues that challenge people's ability to meet their basic needs, right? And that's what I found a lot in my work, right? It wasn't just about whether or not you could fight this deadly disease pandemic, which at the time of my research was AIDS, right? It was about your ability to feed your family, to send your kids to school, and to access clean water so that you could have, you could have a healthy everyday life. And I think that, until people's basic needs are met, I think that's, it's going to be less about comparing COVID-19 to other health issues. But again, if we strengthen the health systems, right, that can kill a lot of birds with that very big and expensive stone.
Okay, I'm gonna combine a couple of questions so we can get the most out of our session. So there was two questions that I think are related. One was about communal systems that cited some of the comments that Simukai made. And the question here is about the role of local community institutions such as traditional leaders to lead the response. And then I'm just gonna add on to that, when we're talking about traditional leaders, we're also talking about religion and religious leaders. So that's two birds with one stone. So Simukai, you were called out by name, so you have to answer it first, but then others can jump in on it.
Great, thanks. So I'm going to cheat a little bit and reframe the question slightly, because I think that sometimes when, naturally we talk about communal systems and we think about, traditional leaders of various stripes and so on. But communal responses are quite diverse, and there are many different forms of community. I think with this particular outbreak, one community that I've seen mobilizing at incredible speed and capacity in relation to COVID-19 in Zimbabwe has been the Diaspora network of healthcare workers. So what we're seeing is lots and lots of Zimbabwean doctors, mostly in South Africa, the UK, the US, some in other parts of Africa, joining on huge online platforms with the express purpose of thinking about how to do information sharing, clinical information sharing about managing the outbreak. And so what they've done is, as the network has grown, they started targeting specific people, asking them to join these networks, but they've tried to get district health officers from every district in Zimbabwe and make sure every part of the country is represented on these online platforms. Then they've talked about alternative supply chains where materials that are being used in different parts of the world, such as PPE and other such resources, might be sent in country. Then they're thinking about, we were talking earlier about some of the difficulties with, say, ventilation and the supply chains around ventilators. The position that the groups that I've been following have arrived at is to forget entirely about ventilation and to, or at least mechanical ventilation, and instead to think about the evidence and strategies around different forms of non-invasive ventilation that can be used in contexts where resources might be a bit more limited, or where power cuts are liable to happen, and so on. They've been looking at different strategies for improvising PPE, personal protective equipment, and so on. It's actually quite elaborate because there's this kind of organic comparison of different scientific bases for the various facets of the response. And I think these are strategies that kind of look up and down, if you like. They look at how networks can create nodes of information gathering about what's happening in different district hospitals, what's coming through the door, and supplement the government's formal public health response. But they also look at how evidence can be tailored towards context. And it's all being kind of driven by this idea, this imaginary that as diaspora, Zimbabweans, and as the healthcare professional, they're part of this epistemic community with a particular sense of civic duty to the country, but one that tries to be explicitly non-partisan. And on one hand, I think this is really innovative and important. On the other hand, it's still a stand-in. It's still something that's, as very sort of unsung heroes fill in the gaps that are left by the government, and might ultimately leave us without adequate political accountability for why we've had to resort to this model of intervention in the first place. So I think the communal responses are kind of multifarious and often double-edged.
Does anyone else want to tackle this question, or do you want to go on to the next one? Okay, this one came from behind, and now is the top question from Daniel Posner. So it's a last-minute entry into the question sweepstakes. But it's a question around political actors using the pandemic as rationale for moving their countries towards a more authoritarian direction. I know Kim already touched on this a little bit, but maybe it's an opportunity to widen it. Daniel's asking about what countries, are there countries that we're seeing this, or countries where we're worried about this happening?
Yeah, so it's always great to get a question from your dissertation advisor while you're on a webinar. So hi, Dan. Welcome to the Zoom. So this rationale for authoritarianism, I think that, certainly, and we've been talking about this, right? Like whether people, ordinary citizens have to give up some of their civil liberties in order for the state to lead a response, right? Because in order to do the isolation, right, it's going to require people to stay in their homes and to participate in these curfews and or lockdowns. And I think there's some really great work on this in political science, so not necessarily in the African context, but Bethany Albertson and Shana Gadarian wrote a book called Anxious Politics, where they talk about how willing ordinary citizens are to give up some civil liberties if there is this threat of disease and they know that it's necessary. And just, I think this past week, Afrobarometer released a report where they show a willingness among African citizens to kind of give up temporarily some of their civil liberties should there be a need, a security need to do so. So I think that, certainly there are opportunities for leaders to do this that might make them more authoritarian in the long run. So once you give up rights, you don't know that you're going to necessarily get them back. So I think that there's reason for some concern, but I do think it's going to depend a lot on the context, right? So just going back to like what Simukai was saying earlier about, there's lots of countries and there's lots of varying levels of capacity, but also legitimacy, right? He talked about political legitimacy. And I think that, the Malawian case that I brought up earlier, where the president tried to institute a lockdown, he was doing that in a country where there is still an independent court system. And the High Court of Lilongwe said, no, President Mutharika, you can't do that. You've got to take care of these concerns that the civil society organization that brought the suit against you have said are necessary, right? You need to deal with these issues first. And I think that even in places where there is potential to move in an authoritarian direction, I think it's going to depend a lot on the other potential checks on executive power, right? So whether or not there's, a vibrant civil society, whether the judiciary is actually independent, And, you know, whether the media has the ability and the capacity to check the government as well, I think is going to shape where we see authoritarian movement on the continent.
I think this is playing out in real time in Lesotho right now as well, where you know, Prime Minister Tamtabane is supposed to step down because of his alleged involvement in his second wife's murder, and he keeps talking about we're in the middle of a COVID-19 pandemic, even though there isn't any confirmed cases in Lesotho, as a way to sort of push back. But Kim, I think to your point, both the region and the civil society is having none of it. And so, I mean, this is live. We're not sure where it's going to end, but just one example that came to mind. Are there others that people want to put on the table, the virtual table? Okay, we have one more question that I want to get to. It's a good one around terrorism and security. And how do we think, you know, questions around security and health will change after COVID-19? What will be the effect on security policies in Africa, and particularly in the way the international community privileges counterterrorism and security? Emmanuel, I see you're about to get it.
Yeah.
Go for it.
Yeah, you know, I think, you know, this is something I'm also starting to think about in, you know, sort of these intersections between obviously between health and security and you know, the capacity to handle some of these things, right? And I think in terms of I think a lot of we've talked about this in different ways here, but you know, I think one of the issues is that you know, I think in the short term, places like the United States seem to be, at least in recent years, have seemed to sort of retreat from having, you know, a robust, active role in security issues, at least in the way, you know, less robust than it had in sort of the institution of AFRICOM in 2007 and sort of the securitization of terrorism in the 2010s. And I think, you know, with COVID, I think it's incumbent upon, you know, the international community, but also, again, looking within Africa, the institutions within Africa to rethink their approaches to things like terrorism. One criticism I've often had of ECOWAS is that while it tries to do too much, a lot of things, it doesn't do any of it well in some regards. But I think in one area that we can definitely look at this is its response to terrorism, right? And so I think one implication of COVID-19 in the context of security I think will, and you see this really in the commission level in West Africa in particular, but there is a drive to sort of link areas or sectors within the institution, particularly linking things like health, development, and security, and developing not just talking points, but actually developing resources and specialized institutions within ECOWAS to approach these topics as well. So, you know, the short answer here is I think that, you know, I would hope to see some policy convergence here, particularly in the context of West Africa, in dealing with not just terrorism, but just, you know, security issues in general, the security of women and children. You know, thinking more about sort of the intersections between health, security, and gender as high politics as well. And so, yeah, I don't. And again, in the short term, it's so as things are so fluid. It's difficult to see, you know, sort of a broader strategy around that links health and security explicitly. But I do think one of the lessons learned out of this will be a need to embed more policy convergence around health security and securitized issues in the region.
Okay, we have just a few minutes left. So what I want to do is open it up to our panelists. If there was a burning issue or point that you needed to get out and didn't have the chance, this is your opportunity. Go ahead, please.
I don't know if it's burning, but I want to push against, and this is going to probably be the hill that I die on. I want to push against the health security frame. I am very concerned about that union between the health and security, but primarily because security is often seen as something that is either militarized or policed, right? And so as we keep talking about the sort of authoritarian regimes, as we continue to talk about marginalization of specific groups and mobilizing security paradigms and frames within health, I am often concerned about who bears the brunt, who's on the receiving end of security paradigms and security frames and security approaches. That said, I can see some of the benefits when those are the most robust kinds of responses coming out of the institutions that we currently have. And we need to think about why that might be and what that means ultimately as we begin to develop and rethink the possibility for good, robust, safe social safety nets and health systems.
That's a great point. Thank you for sharing. Others? Okay, well, my background is tingling, which I think means that we need to wrap it up. So I just want to say that it's really an honor to be able to do this. For those of you who don't know me, I spent my whole career in government until moving to the think tank world. And so I think it's always useful in this setting to say that those of us who were in government or in think tanks, read the work of academics very closely. It helps inform policy formulation and implementation. So I always want to make sure, you're not writing it for yourselves or for each other or into the ether. Like, it is part of the inputs that hopefully contribute to good analysis and good policy. I particularly admire the people in APCG. If you go to ASA, I will try to crash your your happy hours. It's my favorite part of ASA. So thank you so much for having me, APCG. Thank you to our incredible panelists who have so much insights and expertise, and you should be buying and reading their books and work. Thanks to Amanda Robinson and her team for putting this together. And I hope everyone has a safe and healthy day, weeks, and I hope we can do this again sometime. Thank you.
Thanks, Judd, and thanks for everyone who attended and shared your questions with us. We really appreciated it.